So we're going to move right along. This next panel is entitled Hype, Harm, Bias, and Failure in Psychedelic Therapy. And the first speaker needs no introduction, but I'm going to tell you about him anyway. Matthew Johnson, PhD, is the Susan Ward Hill Professor of Psychedelics and Consciousness, Professor of Psychiatry and Behavioral Sciences, Johns Hopkins University School of Medicine, and the Center for Psychedelic and Consciousness Research. I will introduce the other two people in due time. We're going to start with Matt Johnson.
All right, thank you so much, Julie. I just said I was going to talk. I can't, tweak any knobs or anything, right? So, are we all set? Okay. Okay, just need to go into the mic. This is the magic mic here. How about that? Need to get up close and personal with the mic. All right. Okay, well, thank you so much. It looks like people are trickling in. We've got sort of like a pretty packed room, which is kind of crazy because if you think about it, Manoj and Laura and I have maybe the most difficult session here because we're basically supposed to tell a bunch of folks who are super enthusiastic about psychedelics that sometimes psychedelic therapy can really suck and there can be some real problems with it. So we'll try to get through that and let you know there's still some certainly promise, but we had to be aware of some of these pitfalls. But I don't think, actually I really want to thank Kevin for those comments he made to put them into context on the fly, which is really impressive. But I have to say, I don't feel so bad right now telling you about the downsides of psychedelic therapy because Kevin just came up here, I believe, and told a bunch of psychedelic fans that the Grateful Dead might not have the best rhythm timing. So we're not supposed to say that out loud, I guess. Okay. On with the talk. So just by way of disclosures, just showing you some companies I advise regarding psychedelic medicines, although I'm not talking about any of their work or products in this talk. Okay, psychedelic therapy. This is the good side. This is from our group at Hopkins, a mock participant, 2 guides that they prepared with, undergoing this introspective experience, 5 to 6 hours on psilocybin. That's the good part, but let's talk about some of these different categories of harms that I don't think have gotten enough attention. Now, I've published, and I've mentioned in my talk yesterday, published some papers over the years reviewing more of the kind of adverse events, kind of downside to psychedelics that are the so-called bad trips or challenging experiences, people with susceptibilities, vulnerabilities, and all of that. I'm not focusing on that here. These are I see as more sort of insidious harms in waiting that we need to keep in mind as this field moves forward so rapidly. So these categories are expectations of benefit, understanding of risks, clinical boundaries, and metaphysical framing. So let's jump into the first one of those, expectations of benefit. So I think we need to reflect on the environment that we're in now and be mindful of history. We are in an extremely psychedelics positive media environment, and that's really been the case since the beginning of this modern day psychedelic therapy renaissance 20 years or so ago. It's very rare that you see a negative story. And you might think that's different than in the earlier decades, but that's not quite so. The coverage of the emerging psychedelic medicine field was extremely positive in the media up until really the late 60s. But when we're talking about the early 60s, certainly the late 50s, early 60s into the mid 60s, it was, the media coverage of psychedelics was extremely positive. You might recall Life magazine, Gordon Wasson's sort of rediscovery to the west of the mushroom tradition from Oaxaca, Mexico. That was an extremely positive piece and one of the most prominent publications, and that wasn't alone. So we need to be mindful that the media landscape could change. That folks back in those days said within a few years you went from not being able to sell as a reporter a bad story about psychedelics to your editor to just the opposite. You couldn't get, unless it was horrific, you couldn't get it published. But given this media, where we're at right now, we're very likely to see this amplification, this sort of irrational exuberance of excitement for psychedelic work. And one aspect of this is that it's going to work for everybody. And it shouldn't be a surprise because I'm pretty sure nothing in medicine or mental health treatment of any type works for everybody in all cases. But it doesn't work for everybody. And I mean, this hits me very saliently when, for example, people reach out just out of the blue and they are describing either themselves or a loved one that's gone through everything. They're at their wits' end. Oftentimes, you could tell these folks probably wouldn't qualify for the study that they're interested in because they're listing a million things that are exclusion criteria because the suffering is so intense. But I'm very mindful to tell people that to really encourage people to not see psychedelic therapy as their only hope. That's really dangerous, especially right now where there's a lot of positive media and there is very few, at least legal context under which people can undergo psychedelic therapy. So that creates a very difficult situation. So you really want, and it's. So you don't want to put a person in a situation where they really feel like this is the last step and they're completely desperate and they're not willing to undergo more mainstream treatments. But it's also just simply the reality. It's not just good messaging that the person remains hopeful and not see psychedelic therapy as the end all be all. But it's also again just the reality. It clearly doesn't work for everyone. It's not an automatic cure. Yes, sometimes, on average, these results are looking very large. It's helping a large proportion of the people in the preliminary studies, but it's not everybody, and it's not automatic. And so sometimes folks are interested in the studies and they screen, and you have these discussions with them as they're coming into the study. Some folks kind of don't get it. They just have read an article or two or seen something on TV, and they think it's just sort of going to automatically cure their depression or automatically make them want to quit smoking. And it's difficult to convey, but really, in psychedelic therapy, one of the reasons psychedelic therapy, with whether it's psilocybin or MDMA, what have you, one of the reasons I think it really works so well is people do their own healing. They do their own psychological heavy lifting. There's nothing automatic about it. When someone comes out of a wonderful session that seems to have been helpful, they just feel exhausted physically, mentally, spiritually. So it's not easy. So there's no automatic cures. Finally, balance of hope and hype. So given kind of this backdrop, it's difficult to balance and send the right message to convey on the one hand, yes, the data are suggesting that psychedelics for certain disorders are showing very large effects that might help a large number of patients with these disorders that are pretty intractable. But so on the one hand, I truthfully can say I believe that psychedelic therapy is going to be a new major paradigm within mental health treatment. And at the same time, you want to balance that against the hype that it will help for everyone, that it's going to be the only meaningful therapy for people, that it's going to be an automatic cure. So people have their own ways of balancing that. But I found it challenging, but you don't want to go to one side or the other. Sometimes I think colleagues might dismiss the promise because they don't want to fall into the hype. They dismiss the promise of psychedelic, therapy, and you don't hear that excitement when they're describing it, these life-changing experiences. So balance is important. And then I'll say something about the nature of experiences, for example, that people have on psychedelics, a mystical experiencing. Sometimes it's really overstated, the role that this plays. I mean, our group at Hopkins has done a lot of work on this over the years, found that more mystical experiences on session days have a relationship to long-term therapeutic outcomes. But sometimes it's overstated in the media. I remember one article saying the mystical effects are critical or necessary, something like this, for the therapeutic effects of psilocybin. That's not true. It's amazing that any subjective experience during their session is going to be predictive of some long-term positive health behavior change 6 months or a year later. But in fact, especially when you control for just the ratings of how strong the drug effect was, but when you go back and you look at those correlations, I mean, they're not all that strong. I mean, they're significant, they're modest, correlations. And what that means is that, yeah, there's some people that were really benefited therapeutically that didn't have so much of a mystical experience. It might have been insightful, might have had other positive qualities. And then there's people that have a full-blown, complete mystical experience with all of those qualities, transcending time and space, one with the universe, all that. But yet it didn't help the therapeutic target. They didn't quit smoking, for example. So, we need much more work in this area, but it's not such a simple picture that might be conveyed. Let's see. Next major category, understanding risks. So something that we all should be aware of as this stuff, hopefully psychedelics based on the phase 3 data for psilocybin and MDMA over the next several years. Hopefully these are going to be approved for treatment. There will be casualties. I think we need to be clear with folks. If this is disseminated to tens of thousands of people, maybe to millions of people, you're going to have casualties. There's going to be some rate of casualties even if things are done extremely safely. Simply because all interventions have some risks. However, you're going to have more casualties than that, the degree to which, in clinical practice, safety guidelines, the safety mechanisms in place may dip below what we're seeing in the field now in the academic research. So we have to be very mindful of that. But be aware that, yes, there's just, people have medical complications from virtually any procedure, a blood draw, for example, at some rate. We need to recognize that's going to be the case here. And so it all comes down to risk-benefit ratio, and that's not an easy analysis. So under recognized risks, I'll just speak pretty briefly on some of this. It's like leaving the clinic. I don't think we talk enough about that, but one participant left one of Strassman's studies, actually with psilocybin in the 1990s, ran out of the clinic and was on the streets of Santa Fe. It happened not once but twice with a high dose of psilocybin in the 62 Good Friday experiment. One person actually had to be chased down the streets of Cambridge and injected in the rear end with Thorazine because he was trying to find the president of Harvard to tell him about the second coming. So, you don't have to go that far back into psychedelic history to realize, this is a thing and it's going to happen. 10,000 patients are treated out once this is approved. And again, depending on people's the safety mechanisms at place, some folks are going to freak out and leave the laboratory. Hopefully they're going to be okay, but obviously there's a risk there. And we need to, focus more on how to prevent those types of risk scenarios. And there's other harms and things that could be harms, but they could be helpful, but it's such a new clinical beast that we need to learn more about. A lot of folks that have a rough time after psychedelic sessions, I kind of liken it to a midlife crisis. No matter what age, they might be in their 20s, but it just kind of shakes things up. Maybe it's bringing up old trauma, or the person is sort of facing their demons. It can be very difficult, and so we need to really focus on that. And it's kind of difficult to find, and a lot of that type of experience that the integration, it really depends whether that's ultimately harmful or helpful. The sense is it really depends on that integration, which is why it typically is such cases positive in a research therapeutic setting. There's worsening of psychiatric disorders. It appears that in terms of lab research, that's only been in the case of psychotic disorders and similar disorders. But our survey research suggests that garden variety, depression and anxiety, that in a non-clinical context, that a challenging experience can exacerbate one's, after the session, their depression and anxiety. So again, depending on how it's rolled out, depending on the degree to which the clinical infrastructure and integration is there, are we going to see more worsening of those psychiatric symptoms when people, if it's not done well? A whole lot to figure out with personality disorders, both in terms of whether certain ones should be excluded and also potential for treatment. And then belief systems, that's another area of risk. It's been reported that people can, that we might be concerned about psychedelics changing people's political and religious beliefs. And so there's a bit of an exchange in Scientific American. Eddie Jacobs wrote this article, What If a Pill Can Change Your Politics or Religious Beliefs? But myself and David Yadin, also at Hopkins, responded to that really, and I won't go into the details, but really critiquing. We don't think it was a convincing case. We don't think the reports that have been published on changes in politics are very reliable and valid. So I'd encourage you to look at that. It's freely available. It's Scientific American. You can Google it. But I'd encourage you to read this. But we need to keep watching. We should be concerned if there is an effect in changing someone's political stance, their religious beliefs, even though I think the data suggests that that's not, on average, an effect that's going on at this point. But we need to be concerned about it. Got 1 minute left. I wanted to show you my flying spaghetti monster. Some of this content came from a commentary I published. It's my first published artwork. I'll bring this point up just to say, and I'm wrapping up here, but I've made a recommendation in this paper that we be very careful about not imposing metaphysical belief systems in psychedelic therapy, that we are client-driven, client-centered. And we're not there to tell them, no, that wasn't an experience of plant spirits, no, that wasn't an experience of God or Jesus, no, that wasn't, whatever. But we're also not there to drive that. We are simply there, we're letting them drive that metaphysical interpretation, if any of these sessions. So I have made the recommendation in that paper that for example, we not use religious symbols in the Buddha, which has become popular, and so that's why I had the flying spaghetti monster in there. I'm gonna wrapping up in 30 seconds here. We need to cling to some people with psychedelics. In the history of psychedelics, it's often there's this theme of these experiences are so big they can't hold the normal scientific game, the normal way of doing things. It's bigger than that. That's exactly the opposite of what we need to do. We need to cling to our professional training and boundaries from medicine, from psychology, from social work. It's more reason to click to those. For all of the boundary issues we're hearing more and more about, our Laura will be speaking about sexual misconduct. I warn people about the guru complex. It's hard to be. I've been in over 100 sessions with psychedelics with people. Sometimes it's the most important experience in that person's life. That's really heavy. It's a real burden. And we've got to make sure that doesn't go to our heads because we're just playing a role. And it's the medicine and it's that person who are doing the heavy lifting. And I think I'm going to move on. I told you about the Buddha. I'm already a liar for telling you I'd be wrapped up in a minute, but there I am. Thank you to our group, and you can check out our group's website, hopkinspsychedelic.org. But I am done.
I just got such an eye roll from my daughter when I tripped. It was great. It's good. Thank you very much, Dr. Matt Johnson, for speaking. You couldn't summarize the whole sexual misconduct thing in 30 seconds. Luckily, we're going to have somebody else speak about that. And, hopefully at some point we'll just have a whole conference about it because it clearly needs a lot of fleshing out. Am I right? Our next speaker is Manoj Doss. He's a PhD and a neuroscientist, and he is a postdoctoral postdoctoral research fellow at the Johns Hopkins University School of Medicine Center for Psychedelic and Consciousness Research, Dr. Doss.
All right, so can y'all hear me? Is it good? All right, so, say what? Sound here? Oh, up? That speaker's out. Okay, so I'll just try to speak very loudly. Okay. So I'm a cognitive neuropsychopharmacologist. I look at objective behaviors and measures of brain function. So for example, like memory tests. And so I'm going to be talking to y'all today about how psychedelics, as well as some other drugs, affect episodic memory. So, first of all, what's episodic memory? It's the conscious re-experiencing of information from the past, or in the words of Endel Tolving, mental time travel. And so when we should differentiate episodic memory from other types of memory that are typically studied with drugs, such as habit learning or fear conditioning. And in terms of episodic memory, we like to break things up into different processes. So two of the ways we like to break it up is recollection and familiarity. Recollection is maybe the more common way that we think of episodic memory, or human episodic memory specifically. This is the hippocampally dependent retrieval of specific details from the past, like where and when information. Because it involves placing oneself in the past, it's thought to involve autonoetic consciousness. In contrast, familiarity is more of a feeling of knowing. For example, like knowing a fact. You might know that George Washington is the first president of the country, but you don't have the recollection of where you learned that information. And so in terms of episodic memory, one way familiarity might come up every day is that you might see my face one day, and you might recognize my face, but you're not going to remember where you met me, when you met me, what my name is, etc. You're not going to have any recollections, but my face is going to be highly familiar, and so that would be an example of familiarity in the absence of recollection. So whenever we're trying to manipulate episodic memory with drugs, we really have to be careful of what phase of memory that we're trying to modulate. And so, for example, there's the encoding phase, in which you're forming memories, or this is when I'll be showing you a bunch of stimuli, and I can administer a drug right beforehand, for example, and that might modulate the way you're going to now form memories. In contrast, after I show you a bunch of stimuli, I can now give you a drug afterwards, and this would be now manipulating the consolidation phase. This is when memories are thought to be stabilized. And then lastly, I can now test your memory for the stimuli that I showed you, but right before I do that, I can administer a drug right before memory retrieval. And that all of these different phases of memory, when you administer a drug, can have a different effect on episodic memory. And what's important to note is that different memory processes can interact during encoding, consolidation, and retrieval, and that this can produce different types of memory distortions. So I need to define a few drugs here. First of all, psychedelics. I think this is why we're all here. What I'm going to be referring to as psychedelics is going to be serotonin 2A agonists, such as psilocybin, LSD, DMT, 2CB, etc. I'm also going to be referring to MDMA here as a psychedelic. I know that for some people they don't always feel that way. MDMA is actually two drugs. There's the R-enantiomer, which does bind to the serotonin 2A receptor, and then there's the S-enantiomer, which gives us some more kind of common MDMA-like effects, the stimulant effects, and the lovey-dovey, puppy and whatnot. But at least in terms of episodic memory, MDMA does seem to act like a serotonin 2A agonist. It's actually been shown that some of its effects are serotonin 2A dependent in humans. So, and there's dissociatives. Some people refer to these as psychedelics as well for the purpose of this talk. I'm just going to refer to them as dissociatives. These are NMDA antagonists like ketamine, dextromethorphan, nitrous oxide, etc. Then you have your sedatives, your GABA-A modulators, such as alcohol, Ambien, and benzodiazepines. And then the cannabinoids, your C1 agonists, like THC or the spice drugs. I like that one too. So lastly, you have your stimulants. So drugs like amphetamine, meth, Ritalin, bath salts, etc. So why am I telling you about all these drugs? So the question I've had is, do psychedelics uniquely modulate episodic memory? And so first of all, what do drugs do to memory encoding? So it's been shown that drugs, sedatives and THC Although they impair memory, they seem to especially impair the encoding formation of emotional information, such as negative and positive memories. And what's interesting is the drug dextroamphetamine, we give this to kids, ADHD, it enhances the formation of memories, but it seems to especially do so for emotional information. And then lastly, all drugs that impair memory encoding, sedatives, dissociatives, and THC, they've all been shown to impair both recollection and familiarity, at least at higher doses. So now, what do psychedelics do? So here's a study in which I applied a computational model to try to pull apart the contributions of recollection and familiarity separately. And so what I'm showing you here is in the top panel is negative recollections, in the middle panel will be neutral, and then in the bottom will be positive recollections. And for now, just pay attention to that blue distribution. That's when MDMA was administered prior to memory encoding. So while people are forming memories, they're now on MDMA. And that gray distribution will be the placebo condition. And so anything to the left of that gray distribution would be an impairment. Anything to the right of that distribution will be an enhancement. And so what you can see is that MDMA impairs recollection, but it seems to especially do so for the emotional information, both negative and positive. But now, what about familiarity? Well, what you can see here is that MDMA enhanced familiarity, but especially for the emotional information. So now what about psilocybin? This was a reanalysis, so I didn't have the option to look at emotional memory specifically. We are actually working on that right now. But here's just looking at neutral stimuli, and what you can see is that psilocybin, even at these absurdly high doses in which people are barely functional, they impaired recollection, but it seemed to at least numerically start to shift familiarity, enhance it, even at these absurdly high doses again, where people can barely supposedly do the tasks, and yet we do see this slight enhancement of familiarity. So now, what do these drugs do now to memory retrieval? So this is now after you form the memories, I can now give you a drug right before I test your memory. And so dextroamphetamine and THC during memory retrieval have been shown to distort memory. Essentially, people will now claim they saw things they never actually did. And it's unclear what sedatives do. Some people have shown there's no effect, but there was this whole issue in the 90s where people were giving people sodium amidol, which is a barbiturate, and that would result in these memory distortions. People would say they recovered certain memories that were just extremely implausible. So now, what about MDMA? So here's a study I did, and what we showed was that, again, MDMA during memory retrieval also seemed to increase the incidence of false memories. What I'm showing you here is MDMA during encoding or retrieval, and in the purple bars, that would be during retrieval, and this is how likely they are to falsely say they saw something that they never actually did. So just to wrap up, so sedatives, cannabinoids, stimulants, and psychedelics preferentially modulate the encoding of emotional episodic memories, but the way that psychedelics differ is that whereas they impair the encoding of recollection-based memories, they spare or perhaps even enhance familiarity-based encoding. And whereas all other drugs that impair memory encoding really impair both recollection and familiarity. So this makes psychedelics somewhat unique. But what's interesting is that in the lab, we can actually manipulate people to have recollection be low and familiarity be high without drugs. And when that happens, people will report some bizarre phenomena, such as deja vu, feelings like you're having an insight even when you're not actually having an insight, or feeling like you can predict the future. When, if that does not sound like somebody on psychedelics to you, I don't know what does. And so lastly, we did show that cannabinoid stimulants and MDMA all seem to increase during memory retrieval, seem to distort memory. They would increase false memories. It's unclear to me if those effects were due to the stimulant effects of MDMA or due to the psychedelic effects. My guess is it's probably both, and I'll explain to you why in just a second. So here's a little bit of speculation. So the potential good to all this is that the cortex in the brain, where familiarity-based encoding is thought to happen, is thought to be a slow learner. So it doesn't change too much because it's composed of these crystallized memories for the ways that we process like perceptual and semantic information. You wouldn't want, for example, the color red to start being seen as the color green, or else you might find yourself, getting in a car wreck. Or, for example, you wouldn't want to, for example, see a pile of metal and not be able to interpret that as a car, because, then you might be the cause of that car wreck later. And so one thing that familiarity-based learning, because it involves the cortex, might be useful for is disrupting some of these really rigid, crystallized semantic stores, the way that we process semantic and perceptual information. And that could be especially good for people who, over a long period of time, have this narrative for themselves that they've built that is perhaps maladaptive. It's also the case that we just showed this recently in humans, that even after the psychedelic experience is up, that there seems to be these certain plastic or variable-like states. There's some neural flexibility, and it could be useful for triggering what's known as the reconsolidation process. This is retrieve a memory, it undergoes a state that's labile, and now you can distort it, delete it, or perhaps even strengthen it. And so it might be the case that we can now maybe better trigger this reconsolidation process with psychedelics to, again, kind of rewrite some of these maladaptive memories. The bad, though, is that, in general, emotional memories are really hard to forget. If you saw any of those distributions, the negative stuff was always remembered better than the neutral or positive stuff. And generally speaking, repressed memories are extremely, extremely rare. And so for anybody that is entrenched in a sort of Freudian framework, I really recommend you look into Elizabeth Loftus's work. I mean, she was showing that, look, if there's this many people in the 90s that are reporting having satanic parents that abuse them, when there aren't even that many Satanists in the world, and as many of you will probably know, Satanists aren't necessarily bad people, that chances are it's very implausible that these were actual recovered memories. And so because psychedelics and MDMA have been shown to enhance mental imagery, and it's been shown that mental imagery can help facilitate false memories, that it might be the case that these drugs could, in theory, cause some false memories. It's also the case that recently encoded familiarity without any sort of form of constraining where that familiarity is coming from, in other words, not having any recollection, could also result in false memories. This is work from my PhD that didn't even involve drugs. And then lastly, although I did mention reconsolidation as being a good thing to rewrite certain maladaptive memories, it might also be the case that reconsolidation could result in something maladaptive itself. So I just want to say thanks to my collaborators, thanks to our funders, and if you don't already, please follow me on Twitter.
I would like to say that I do happily follow Dr. Doss on Twitter. Our next speaker in this same vein is Laura Mae Northrup. She is a licensed marriage and family therapist and an author and psychotherapist. And I think she's going to be talking a little bit more about something that I know I want to hear a lot more about, and I think other people do too, which is this issue of transgressions. Laura Mae.
Ooh, there's lots of stuff up here. Hi, everybody. Can you hear me okay? Yeah? Okay. It's an honor to be here and be able to speak to you about such an important topic. I am here to talk about sexual abuse in psychedelic therapy. And I want to acknowledge that this is something that many of us have been deeply impacted by, and especially as of late. So it's on a lot of people's minds and hearts. Talking about sexual violence is very difficult. In ways it's just intolerable to take in. And so a very normal and understandable response is to defend against it. So I just want to start by inviting you to stay in the room. And I don't mean not leave your seat or not close your laptop if you're on live stream. I really mean to just stay here. So sexual abuse in psychedelic therapy happens when the therapist or guide sexually violates the client or patient that they're working with. Oh, can you hear me okay still? Sorry. Violations can be physical or non-physical. And they often occur in a way that makes the client uncomfortable, as in at the time they know that they don't consent. And other times, sexual violations can look consensual. But consent is greatly compromised in relationships where there's a severe power imbalance, which is always the case in psychedelic therapy. Research shows that most sexual relationships that seem consensual between therapist and patient are eventually reported to be traumatic in retrospect. And at times, clients can experience symptoms similar to incest survivors. As an empathogen, MDMA-assisted psychotherapy can radically affect how a client feels about their therapist. And generally speaking, psychedelic medicine can invoke a high level of idealization from the client toward the practitioner. In any case, it is the therapist's duty to respond in a manner that is therapeutic and in the frame of the therapy. I want to be clear. There's another sound coming over there. I want to be clear that having sex with the client or patient in a psychedelic therapy relationship is always sexual abuse, and that is because of the power dynamic. I only get 10 minutes, you guys, so we gotta... You just took up like 10 seconds. No, so what we know from research in the US, looking at mental health clinicians in non-psychedelic spaces, is that mental health clinicians self-report engaging in sexual violations with their clients at rates of 7 to 12%. We don't have data on corresponding rates to psychedelic therapies, but we have no reason to believe it would be any less than our non-psychedelic counterparts. 7 to 12% of clinicians self-report. As in, these are the people who admitted what they did on their own accord, that they have sexually violated one or more of their clients during their careers. That is a really big number. And what we know from the research, and it's also been the case in some of the major call-outs, is that the people who are more likely to be sexually abused by their therapists are people who were sexually abused as kids. We are standing on stages like this one and inviting extremely traumatized people who are incredibly vulnerable to heal their PTSD. And some of them are coming to us only to be sexually abused even further by the person who they trusted to help them. Clinicians with and without a personal history of trauma can and do abuse their clients. We live amidst a global epidemic of sexual violence that normalizes these behaviors. However, another very painful thing to acknowledge is that the limited research suggests that clinicians who are at higher risk of sexually abusing their clients are male clinicians who were sexually abused as kids. This is a cycle of abuse. I could stand up here and name names and get deep into analyzing each case we have information on, or become self-righteous, or make a grandstand, or do a myriad of things that might make myself and everyone else feel momentarily more validated and less sick inside. And they're all compelling things to do. But none of that is actually going to stop this abuse. I have one simple message for all of us, and I bring it humbly as your peer, as your colleague, as a trauma survivor, and as a client who's healed my own PTSD with psychedelic medicine. We need to heal ourselves. The reason we cause harm is a combination of being wounded and having the power to do it. The reason we don't speak up to stop it, the reason we struggle to believe it, and the reason that we don't prioritize talking about it in every psychedelic therapy training is because we are wounded. There will always be people who are so far gone in their trauma that they will not elect to heal or see the harm they are causing. But those people are allowed to cause harm in part because the community surrounding them is too traumatized to react. Everyone in this room and everyone watching via live stream who wants to support psychedelic medicine in some way, even if you are not the therapist or the guide, you are a part of a community that needs to protect the people we ultimately serve. Each of us has a story, and we have real and honorable reasons for feeling afraid to say something, being too triggered to engage, or too disempowered to take action. And so many of us walk that line between being in the role of our adult professional selves that are ethically called to take action and those very wounded parts of ourselves that also needed protection and help and didn't get it. Each and every one of us, regardless of what types of traumas we've experienced, needs to be doing the deep healing work that it takes to overcome the violence that we have been subjected to or witnessed in our own lives. I do not care how famous you are. I don't care how rich you are, how many psychedelics you have used, or how many years you've been in the game. No one is above their own healing. And to everyone in this room who is a survivor of sexual violence, healing from sexual trauma is excruciating. It truly is. It is one of the hardest things I have ever done in my life. I have sat through journeys where I was in so much pain I thought I was going to die. And I really understand not wanting to do the work or putting it off until some unknown time in the future that never comes. Experiencing sexual violence is no one's fault. But it is your responsibility to heal and not put it on someone else, and to end the cycle of abuse. If there is anything I can offer you today, let it be the hope and courage to heal. Being a healing practitioner is a sacred role, and it comes with incredible sacrifice. You are your own instrument, and you are required to heal beyond what you might choose to do if you are not on this path. The power inherent in our work. Being with someone who is inebriated and emotionally, psychologically, spiritually, and physically dependent on you, that power is immense. And when you enter the room, you bring all parts of yourself, including the wounded parts. And you have to know that the parts of you that are lonely, that are ashamed, that have never felt good enough, or that want to revel in being idealized, have their needs met some other way. Additionally, it is critical to understand how trauma manifests in the human psyche and in the therapy relationship. So many of us are working out of our scope of competence and need more trauma training. And psychedelic medicine is somatic work, psychological work, and spiritual work. Body, mind, spirit, y'all. And most people practice in all three of these realms while only being trained in one. When we work with severe trauma, our clients can do things we experience as psychically disturbing. Richard Jensen, who sexually abused a patient in a MAPS trial, said his victim was a skilled manipulator, which is an egregious thing to say about someone he victimized. And being a skilled manipulator is a PTSD symptom. If you want to work with trauma, you need to have a core of integrity that is so strong that when the room starts to bend upside down because you have entered the realm of your client's very traumatized psyche, you still know which way is up. I truly believe in the power of psychedelic medicine, but psychedelic therapy is only as safe as the therapist providing it. Y'all, we are not doing that well as a species. We aren't going to collectively survive our own coping mechanisms without the skilled work of healing practitioners. And so for that reason, I hope that each and every one of us will keep choosing to heal, no matter how hard that path is, because this is a world that desperately needs us to be well. Thank you.
Kevin would like to say a few words, and then we'll continue with the Q&A on this section.
I want to thank again Laura May Northrup for the courage to come and speak in this topic in such an authentic and forceful and important and delicate manner, and to so elegantly and concisely express so many of the things that we are all going to see unfold over the next few years. And everyone in this room has an opportunity to influence. Here at Horizons, as a lot of you may remember, in 2018, we had the person who had formerly been the host and moderator of this program and who had been a long-serving board member that we received credible complaints of sexual misconduct about, and ultimately made the decision to terminate and release a public statement about it. And I wish that that had been such a unique circumstance or situation, and that my experience as someone leading an organization had been singular. But unfortunately, as has been discussed here, it is not uncommon, and there are many people in positions of power and authority who do abuse them, and who furthermore expect to get away with it, and who have for a long time. I also want to share a conversation I had with another female community leader who didn't want to be mentioned and didn't want to speak publicly to this topic at this time, but who I had a number of very insightful and interesting discussions with about this topic recently. And when invited to present at Horizons on this topic, they explained that for a variety of reasons they were not going to do so, but that one of the things I hope we were looking at is that, with great respect for Laura May Northrup, that for too long, too many conferences present this as a women's issue and bring out female speakers to talk about sexual abuse and sexual ethics, when in reality, this is more often, although as recent events have shown, certainly not exclusively, a problem of men and males. And most of the people in this community who to this day, who control budgets, who control workforces, who control journals, who control positions, who control studies, are often men. And that person told me that what they would really like to begin seeing is men, and in particular empowered men in this community, very, very loudly and clearly speaking up about the impropriety of not only sexual abuse and misconduct, but other kinds of power dynamics that need to be addressed, and that it should not remain something that is seen as a topic for women to speak to, when in fact the problem is more often than not men. So with that, I'm going to bring Julie Holland back to the podium to moderate our Q&A. And I also mention that anyone on the stage is free to answer or not answer any question they want on this topic, and that there is no expectation that anyone will address the particulars of any specific incidents. Thank you all very much.
Well said. Can we have the first concise question, please?
The question is this concept of spiritual bypass, meaning that I think Matthew had said, like in the article, it's so sacred that normal rules don't apply, and yet I know you all believe that more than ever do they apply in terms of boundaries. And they mentioned this thing about transference from the client, and I think you were really talking about that without saying that word, maybe more activated, and counter-transference may be more activated, and just in our clinical training, and I train counselors, so that's something that, well, I just want you to address that, how we deal with those enhancements. Transference.
Does anybody want to define transference, countertransference, and spiritual bypassing is the question. So this is working.
It's not working.
It's just not working.
It's kind of like,
But I don't know how far it's going to go. So maybe come up with an answer.
Yeah, so I didn't use the term countertransference or transference in my talk because I wanted to make it really accessible for people who don't know those terms yet or may never need to know them. But basically, we're talking about how the client feels towards the practitioner and how the practitioner feels towards the client, and sort of what might not be totally real. So for example, like mom transference would be when a client feels like their therapist is like a mother to them and maybe starts interacting with them in that way. And one thing that is really not talked about very much is sexual transference or what's called erotic transference and erotic countertransference, and that's where you feel sexual feelings. It's really normal. It's normal. Therapy is a really intimate experience. It's so normal to be like, ooh, I wish we could go to coffee together, or I wish you were my mom, or, all these things. And one really important thing that we can do is just normalize it so people can talk more about it. And certainly some people do, but there's a lot of stigma around it. And this piece about spiritual bypassing, I think this is really critical to understand when we talk about psychedelics. You can use anything as a defense, anything. It could be your spirituality, it could be, people all the time are like, I've taken so many psychedelics, and that's why I said in my talk, I don't care. If you're not doing the work, it doesn't really matter. It doesn't mean that you're a safe person just because you've done so many really high-dose mushroom journeys. So, yes, spiritual bypassing is a huge issue. And, but I want to just go back to that thing I said about the community being too traumatized to react. Because there are going to be people who we hear about in the news who are just acting in a way where I don't know that they're going to do their healing work. But we need to heal our freaking selves so that we can actually react and protect the community. A lot of times the people who are the most narcissistically inclined, that are seek positions of power and do the worst abuses, are people who, y'all, in their training programs, people were concerned. People were concerned, and they weren't actually willing to say, look, I don't think you should be a practitioner, or I'm not willing to train you. And if you are a person who runs a psychedelic therapy training program, I want to really inspire you to think about who you're training. And if you do not feel comfortable with someone, if you would not refer clients to that person, or patients, or whatever, journeyers, whatever you call them, why are you training them? I understand, you might need to train them up so that you could refer to them, but this is stuff we have to be thinking about. Next question.
Hi, so I'm wondering, Matthew was talking about the side effect of increased psychiatric disorders and personality disorders, but I also know that you're on a spiritual journey. A lot of people describe this like dark night of the soul sort of experience, so I'm wondering, is that maybe best, is there a way to frame that as a feature rather than a side effect, a feature that people should be made very well aware of that this could happen, but is there a balance between feature versus side effect, I guess?
Right, okay, yeah. Good question. So about sort of the dark night of the soul, and that sort of, I think I referred to that essentially as a midlife, something like a midlife crisis. Yeah, so, we include this in, I wish I could give you the exact language, but in our consent forms, and in our discussion when people come into studies. And it's that type of thing that I hope is not lost, as this field moves forward and as these treatments get approved for mainstream use. Yeah, and it's difficult. I think it's, even though this is applicable to the treatment of depression and substance use disorders, whatnot, I think the analogy there for across the psychedelics and therefore the treatment of trauma, and much of what we know about the treatment of trauma outside of psychedelics is sort of at play when using psychedelics to treat these other disorders. Because guess what? There's a lot of trauma underlying these other issues we're treating, and it tends to pop up. Well, what I mean by that is healing necessarily entails something very difficult. It's not going to be easy going through those cognitive processing therapy sessions, for example, prolonged exposure therapy sessions in the context of behavioral treatments for PTSD. So I think it's much like that. The whole process could be overall bad if you get all this stuff to the surface and then you don't engage, you drop out of the treatment, and there's no integration, you're in a context without integration, or so it can be very bad. But that entire process in the long term is the path to healing, is to resolving, to processing the trauma. So I think whatever that is, something very similar is going on, even using psychedelics to treat things other than PTSD. It's a good way to think about it, like as you, and hopefully, I think if you're going to have a deep session, hopefully it's going to be deep and difficult in aspects.
I want to say a quick thing, and then Laura may wants to say something else, which is, something to keep in mind if somebody is going through a really tough trauma is sometimes they're also just coming off their meds because they want to do this work, and then you really have this horrible kind of double whammy. Somebody who's in a really bad place sort of pharmacologically and then psychically, spiritually. And so when we're talking about sort of pitfalls and things to look out for, this is a big one.
Yeah, and I just want to add in on that. So I have a podcast that's about people who are using psychedelics and entheogens to heal sexual trauma. And there's an interview on that podcast that's about somebody who had what was called soft psychosis after using MDMA, and talks about how difficult the experience was. And I think one of the things, so I'm recommending it if people want to listen to it, but one of the things that I think is really important to point out in this is that, for some people they have an experience that's maybe considered negative, but part of what makes it negative is that we live in a very ableist world that wants you to be able to go to work and doesn't really have the resources or the system set up for somebody to have an experience like that. And I've talked to many people where they maybe have previously had psychotic symptoms and they want to do medicine work and their psychedelic medicine work, and they're not sure what to do about it because it's like, well, what happens if I have another break? And I do not feel like, as a person who doesn't have psychotic symptoms, that I have any right to say whether or not they should or shouldn't do it. But what I do know is that we live in a system that makes that very, very difficult because we treat people who have psychosis and psychotic symptoms very poorly and don't give them enough support.
And there's a whole very complicated issue of consent when somebody is psychotic and what they can or can't. But, the way I think of it is sort of like if somebody's in a coma and you assume they can hear you. If somebody's psychotic, you have to still assume that there's somebody in there who's trying to dictate their own care. We're going to take a very short break to smooth out some of the tech issues, like 5 minutes. Please don't go far. 5-minute tech break, and then we're going to restart.